So thank you very much for staying right to the end, which I really appreciate. So there's been already some talk about resistance in Aspergillus, so I will share with you some more recent insights we have gained in the Netherlands. So if you are from the UK, the question is, should you be concerned about resistance in Aspergillus? And are you aware of it? So a recent study performed in the US, they asked infectious disease specialists, are you familiar with azole resistance in Aspergillus fumigatus? And 50% responded saying they were familiar. And only 14% were aware of a possible link between resistance in Aspergillus and the use of fungicides. So the US is a country where little has been reported, low levels of resistance. But any strategy starts, of course, with the clinician knowing about this problem. So this is again a map of the world. This is not the British Empire, as we saw yesterday, but this in red are the countries which have reported azole resistance in Aspergillus fumigatus. It is impressed, but already outdated. But if you look at the mutations, you find these combinations of 10 repeats with a point mutation in the CYP gene, and these are the two very dominant resistance mutations. If you go through the recent literature and you look at the frequencies, you can see that in some countries, like in Germany, 1.1%, in Switzerland 1.3%, also in the US, a year ago it was 0%, but now it's 1.4%. Some countries report 0%, and other countries like China and Taiwan, they report higher levels. So there's a very high diversity in resistance frequencies. As you know, there are two routes, we think. So the principle is the same. You expose Aspergillus to azoles, and you have the patient route where resistance emerges in the patient, and the other route is that you expose them to fungicides in the environment, and resistance arises in the environment. So these patients, they inhale spores which are already resistant. So the problem is that the azoles we use in the environment, they cause resistance, and the medical azoles we use are quite similar to these. So you get resistance mutations against the fungicides, but then the medical azoles don't work anymore. So depending on the host group and Aspergillus disease, the route of resistance is different. So in chronic Aspergillus cases, aspergilloma and chronic pulmonary aspergillosis, you have much more frequently the patient route. These patients usually have chronic lung disease with a cavity. You find multiple resistance mutations, and often the isolates have a fitness cost. So they go white and they grow less well. But in invasive aspergillosis, this is exclusively dominated by the environmental route. So the spores are already resistant. You find these tender repeat mutations, but also you find mixed infections if it's in the lung. If you have it associated with influenza, we often find mixed infections, but also tracheobronchitis. And in CNS aspergillosis, we have a significant problem with the treatment. So what is important to know? Well, the first, of course, is to know is how high is the risk of resistance in your hospital. And the second important question is, does it really matter if you have resistance? Does the probability of mortality in your patient increase if he is infected with a resistant isolate? So what is the resistance frequency? And already alluded to, that is very difficult to determine. At least we have to agree on how we are going to determine that. So this is a theoretical situation. You have 200 AML patients at risk. 20 develop invasive aspergillosis. 6 of those are culture positive, and 2 are azole resistant. So 2 out of 200 is only 1% resistance if you have this as denominator. If you take the number of cases, it's 10%, 2 out of 20. But if you take the number of culture positives, it's 33%. So this is very confusing because sometimes we just look at cultures and we use culture positivity as denominator, and this causes a lot of confusion. So I think it's time that we define how to measure this resistance and how to report it in order to be able to compare the different studies. So in our country, we have a surveillance network in 5 university medical centers. And what they do is they screen for resistance in unselected clinical isolates. So any isolate which is cultured, it might not be clinically relevant, they screen for resistance. And each year, between 600 and 800 patients are positive. So the resistant frequency is then expressed as the number of patients with an azole-resistant isolate divided by the number of patients screened. So if we look at the trend over 5 years, you can see that there is an increasing trend, and this is the resistance frequency in 2017. So this center has 23% resistance, and this one has 10%. So now all centers are above 10%, which is kind of a threshold to think about changing your primary treatment strategy. But the important question is, what does it matter if you have resistance? And there are case series which show that you have high mortality in patients with resistant infection, but it has never been controlled or compared with patients with susceptible infection. So 3 centers in the Netherlands, they did a cohort study, retrospective cohort study, over 5 years, looking at all patients with a positive culture. So the good thing is that all these were screened with the VIP check, which is a method to pick out resistance, and then the mortality was compared in patients who had a resistant and a susceptible infection. So this is the VIP check Agar plate, where you have a growth control, you have a well with ITRA, with Verweij and posaconazole, and it's very easy to see if you have a susceptible isolate, it only grows in the control well, but if it's resistant, you can see that it also grows on the wells containing azoles. And this has a very high sensitivity of 98% in picking out resistant isolates. So these were the people who did it, Alexander, Robert, and Bram. They looked at all the data, and we had 2,266 patients who were culture positive in this 5 years in these 3 centers. So all these patients were analyzed, and we ended up with 196 patients who could be classified according to the URTC MSG criteria and the criteria of Blot et al. So 170 patients had a probable infection, 43 unproven, and 36 a putative infection. So if you look at the resistance phenotype, 159 patients, they had a susceptible infection, and 37% had a resistant infection, which is 19%. If you look at the underlying resistance mutations, again dominated by this 10-repeat 34, which is about half of the patients, 10-repeat 46, but also there were 5 without a known resistant mutation. So I think this is associated with the environment, but we don't know which mutation is present. But at least for 87%, it was present an environmental mutation. Also, there were 7 patients who had a mixed infection. So mixed infection is something we also see with this environmental exposure. 6 patients had a susceptible and resistant isolate, and 1 patient had 2 resistant isolates. So these mixed infections is actually quite common. About 1 in 5 patients has a mixed infection. If you look at the resistance phenotype, of course, all the isolates were resistant to voriconazole with an MIC above 2, but most of them were also resistant to itraconazole and also to posaconazole. Also, there was a 100% cross-resistance between voriconazole and isovuconazole, and all the isolates were susceptible in vitro to amphotericin B. So, 85% from these patients had been admitted to the ICU at some time of their hospitalization, but there were 59 patients who started treatment while on the ICU, and that is what we consider the ICU population. If you look at the underlying diseases, most patients had a hematologic malignancy, 103. There were 24 patients with a solid organ transplant and 24 with autoimmune disease, and there were a number of other underlying diseases. So how were these patients treated? Well, most of them, 80% nearly, were treated with voriconazole monotherapy. There were 27 patients who started on liposome amphotericin B, and then there were a few other patients who received combination therapy. So what is the outcome of these patients? So we compared the outcome on day 90 and on day 42, And this is the cumulative survival. So on day 0, there were 158 patients with voriconazole susceptible infection and 37 with resistant infection. On day 42, 72% was alive with susceptible infection compared to 51% with a resistant infection. And on day 90, it was 63 and 38%. So this was a highly significant difference in survival. But if you then look at the ICU population, this is of course a much smaller group, 59 patients. You can see that the mortality is higher or the survival is lower. And you can see that also patients with a susceptible infection die. So there was no difference in this patient group if you look at mortality between susceptible and resistant infection. However, if you leave this out, because this was a retrospective study, and this is, of course, an important confounder to mortality. So if you look in the non-ICU patients, you again see that there is a significant difference in mortality. So on day 90, 75% was alive in the susceptible group compared to 43% in the resistant group. So if you look at the patients who started on voriconazole therapy, and they had a susceptible infection, we found that 15 out of 111 went to the ICU. But if they had a resistant infection, it was 31%, and this was also significant. Also indicating that these patients, they fail when they are treated with voriconazole. So what about liposomal amphotericin B? If the patients were treated with liposomal amphotericin B, did they do better? Well, here, the purple line is actually voriconazole, and the blue line is liposomal amphotericin B. So the patient receiving liposomal amphotericin B had a significant poorer survival. So and this is, of course, a problem with the retrospective study, because if you look at the characteristics of those patients, they were much more likely to be admitted to the ICU. So apparently, liposomal amphotericin B was given to sicker patients. So I don't think we can draw any conclusions. The only thing I think we can learn from that is that you have to start treatment as early as possible. So with this information, the question is, how do we manage these patients? So one thing you could do is escalate. Keep calm, as the British like to be. You start with an azole. If you find resistance, then you give combination of liposomal amphotericin B. The other strategy is keep calm, but de-escalate. So you start with liposomal amphotericin B or a combination, so you also cover resistance. And if you exclude resistance, then you de-escalate to azole monotherapy. So if you look at recommendations, the IDSA, they recommend an escalation strategy. They don't recommend to do any MIC testing. But if a patient is suspected to have an azole-resistant isolate or unresponsive to antifungal agents, then you should do an MIC test and change your treatment. So the ESMID is a bit more aggressive. They do recommend to do MIC testing on all patients who require antifungal treatment. So what happens? Well, actually, in our study, we did an escalation strategy, but with intensive monitoring, with screening and MIC testing. So we looked at the patients who received voriconazole, and we defined appropriate as if this isolate was susceptible and inappropriate if it was resistant. And you can see that the survival in patients with inappropriate treatment was, again, significantly higher than with appropriate treatment. So despite intensive screening and also switching, we still find a higher mortality in patients with a resistant infection. So when based on culture, the median time to switch was 10 days, and it only occurred in 18 patients. So other patients had probably died before resistance was detected. So probably we need to switch earlier if we want to do an escalation strategy, and maybe a PCR-based strategy is where you find the mutations directly in clinical samples would be a good approach. So what about prophylaxis? Well, azole prophylaxis with posaconazole, you could say, well, it might be a risk because you might select for resistance, or it might be beneficial if you can prevent resistant infection. So based on animal models, we calculated that you would need a plasma level of 1.5 if you use posaconazole as prophylaxis to prevent resistant infection, because most isolates have an MIC of 0.5 for posaconazole. So that's about twice as high as what is recommended now, which is 0.7. So if you are above this level, we think you might be able to prevent resistant infection, but if you are below, probably you select out the resistant isolates. So it remains a question how best to manage our patients. So in high endemic regions, we think you need to do resistance screening, MIC testing, and if cultures are negative, PCR, and have a de-escalation strategy. But most countries, they are low endemic. And then it's much more difficult because an escalation strategy might come with a higher mortality. And do we have to look at all these isolates for resistance? And also, if you have a moderate situation between 5 and 10%, it's very difficult to decide which strategy is optimal. So in the Netherlands, in December last year, the guideline was changed. We recommend to do a maximum effort to diagnose the infection, really to try to get the fungus, to do an MIC test, or do a resistant PCR. Then you have 4 possibilities. So you have confirmed susceptible, confirmed resistant, unknown, or mixed. And we recommend azole monotherapy only in cases where you have confirmed susceptible infection. If it's confirmed resistant, we recommend liposomal amphotericin B. And in the other situations, we recommend combination therapy. So either an azole with liposomal amphotericin B or with echinocandin, and also for the mixed infections. So there's been a lot of debate in our country about this strategy, but I think that our data support a de-escalation strategy. So what other observations? I just wanted to share 2 other things which we found in our country. So if we look at the resistance mutations we find, in 1998 we first find this 10-repeat 34L98H, and that has been very dominant in worldwide. And in 2009 we found this mutation in isolates which also spread across our country and was also found worldwide. But when we look in 2017, we analyzed 229 resistant isolates which we had. You see this pattern that the diversity is increasing. So we have this 10-repeat isolate which has an extra mutation here. You have an isolate here without the 10-repeat, and you have isolates here with 2 extra mutations. Also, we find isolates which don't have 2 copies of the 10-repeat, but 3 copies, and this one has 5 mutations in the CYP gene, and this one has 4 mutations. Also, we find isolates with point mutations, some of which we don't know what they mean, or if they are associated with resistance, and for some, like this one, it's known that they're associated with resistance. And also, we find resistant isolates without CYP mutations. So you can see that what you would expect with continued exposure to azoles, you'd get increased diversity of resistance mutations. So TR34 is still very much the dominant resistance mechanism, followed by the TR46. But 14% now of our isolates, they don't have any CYP mutations. And I think that's, of course, a worry if you want to develop diagnostic tests to identify these directly in clinical specimens. So the other observation is, of course, where is this originating in the environment? And we developed a concept of a hotspot. And the hotspot is an important area where resistance is facilitated or develops. And there are 2 important characteristics. And first is that Aspergillus fumigatus has to be able to grow and reproduce there. And the other is that there should be azole residues present. If you have these 2 factors together, then you have a risk of resistance. And we analyzed a number of hotspots, a number of samples, and we found that wood chips, green compost, and flower bulb compost, they are really hotspots. So they are very much dominated by resistant Aspergillus. But you have to look more in detail, where does the risk for resistance develop? So if you look at the application of azole fungicides, usually the land is sowed for crops. You apply your fungicides, then you harvest your product. then there is waste from the land, and this contains azole residues that then undergoes composting, and then it's used to fertilize the soil. So composting itself, the active composting, actually gets rid of your fungi. And that's why farmers are able to use it again to fertilize their land, because the temperature is too high for molds, including Aspergillus, to survive. However, this is the collection of waste, is the high-risk procedure. So the farmers, they collect over months this waste on their land, and then when they start composting, the Aspergillus disappears. But this, we think, is the risky part if there are azoles present. So how to deal with invasive aspergillosis? I think it's important now to know what the local epidemiology is in your hospital. Even if it's low in the country, still there are hospitals which might have very high levels. It's more and more important to diagnose, to know what kind of fungus you have and what the resistance profile is, to do resistance testing. And also to have an early intervention, because our data, I think, they support that you have to be right when you start treatment. But what the optimal strategy is, I think, is still room for debate. So if you want to have a real experience of resistance, I want to invite you to the ISHAM, because that is in Amsterdam. And I'm sure you will survive the exposure to resistance, because the Dutch survive it, but you're very welcome. And I thank you for your attention.